Welcome you to the interesting topic autoimmune diseases. What if your body's best defense system, the immune system, suddenly mistook you for the enemy? Instead of attacking the viruses or bacteria, it goes after your skin, your blood vessels, even your unborn child. Oh my god. This is not science fiction. This is all about autoimmune diseases. Let's see. A young woman in her 20s, otherwise healthy, has had 3 consecutive miscarriages. Her lab shows a prolonged APTT, but she isn't bleeding. So what's going on? Let's see. So let's see about the antiphospholipid antibody syndrome. Here in this woman, there are 2 antibodies. So that is in APLA, antiphospholipid antibody syndrome, the culprit is anti-beta-2 glycoprotein antibodies and anti-cardiolipin antibodies. The anti-beta-2 glycoprotein, the beta-2 glycoprotein molecule is the one which is present on the plasma membrane. The cardiolipin is the one which is present on the inner mitochondrial membrane. So when there are antibodies which are directed against the beta-2 glycoprotein or the complex with which the beta-2 glycoprotein forms, then the cells undergo thrombosis. So the thrombosis will result in recurrent miscarriages because it can result in thrombosis of the placental vessels too, resulting in recurrent miscarriages. So what is the clinical paradox? The clinical paradox though is that even though there is thrombosis inside the body, they do have a elevated APTT. What does that mean? Elevated APTT indicates a bleeding disorder. Why do we have an elevated APTT in vitro? Because the reagent that is added in while testing for APTT is neutralized by the anti-beta-2 glycoprotein or antiphospholipid antibodies. So therefore it will not clot and it will show an elevated APTT. This is the reason for the clinical paradox. And it also presents with false positive syphilis screening. Syphilis screening is done with VDRL test. In VDRL testing, we use cardiolipin, while the anticardiolipin which is present in the APLA will react with the cardiolipin which is used in VDRL testing, and VDRL test will be positive. So in those with APLA, the VDRL test will be positive, indicating a false positive syphilis screening. In another case, an elderly man develops large tense blisters, but they don't break easily. And his biopsy shows immune deposits beneath the epidermis. So these aren't infections, these aren't allergies, these are the consequences of body's immune system turning against itself. So welcome to the other autoimmune disease, that is the Bullous pemphigoid. Here the immune system targets the hemidesmosomes, which will anchor the epidermis to the dermis at the basement membrane. So when there is an anti-hemidesmosome, that results in a bullous pemphigoid. This will create the characteristic linear immunofluorescence. So obviously in clinical feature, it will result in subepidermal blisters. It will usually spare the oral cavity, and there is negative Nikolsky sign. Nikolsky sign is when a shear stress is applied on the skin, it will give way because of the antibody which are present. But over here, the antibody targets the hemidesmosomes which lie deep. So therefore, there is a negative Nikolsky sign. What about Pemphigus vulgaris? That is almost similar to Bullous pemphigoid, but here the target is anti-desmosome or anti-desmoglein 1 and 3. This desmosome is important for the adhesion between the keratinocytes. So when the adhesion between the keratinocytes is disrupted, then it will result in intraepidermal blisters. The blisters will happen within the keratinocytes itself. This is the Pemphigus vulgaris. While we saw linear immunofluorescence in pemphigoid, here in Pemphigus vulgaris there is net-like pattern. So what about the Nikolsky sign? since it is happening between the epidermis, that is the top layer of the epidermis itself is affected. So when there is a shear stress is provided, the skin will give way and therefore positive Nikolsky sign. What about the Goodpasture syndrome? Here there is anti-collagen 4, that is antibodies against the glomerular basement membrane which contains the collagen 4, targeting the glomerular basement membrane. Therefore, these patients will have a hematuria, along with it hemoptysis. It too creates a linear immunofluorescence pattern on renal biopsy. At this juncture, there is another condition known as Alport, which is X-linked disorder where there is genetically mutation of the type 4 collagen. So it will be presenting similar to Goodpasture, like it will also be presenting with the hematuria, but with ear and eye problems, and the pathology, the basic pathology is different. While Goodpastures is due to antibody, Alport is due to genetic defect. In granulomatosis with the polyangiitis, which is also known as Wegener Granulomatosis, we have the antibody marker C and K, which is also known as antiproteinase. This presents with a triad of hematuria, hemoptysis, and with nasal septal perforation, mastoiditis, and sinusitis. The mononeuritis multiplex can occur in conditions like this. What happens with eosinophilic granulomatosis with the polyangiitis? This is known as Churg-Strauss syndrome. Here the P and K antibody is positive, while in Wegener's we had C and K and antiproteinase. Here we have P and K and anti-myeloperoxidase. So this is characterized by eosinophilic predominant presentation, such as asthma with marked eosinophilia and the systemic vasculitis. Mononeuritis multiplex can present in any of these diseases. Microscopic polyangiitis is again a P and K anti-myeloperoxidase antibody pattern similar to Churg-Strauss, but the clinical presentation will be different. They will have a predominant renal involvement, presenting with hematuria in a patient with a positive P and K. If you had seen, the Wegener's will have a positive P and K and a renal involvement. But here but in Wegener's they will be having a positive C and K. So when there is a renal involvement with the P and K, then it is microscopic polyangiitis. As I told you, in Wegener's, in Churg-Strauss, in microscopic polyangiitis, mononeuritis multiplex can occur. Let's see the most common autoimmune disease, that is the systemic lupus erythematosus. They will be presenting with multiple symptoms. I will tell you about it in the next slide. First, they will be having antibodies. Of course, that is what the disease is, right? Autoimmune. The anti-dsDNA, anti-double strand DNA will correlate with the renal prognosis in lupus nephritis, but it is not specific. Then what is the specific to diagnose SLE? That is with the anti-Smith antibody. So that is the specific for SLE. What about the antibodies against the cell lines? They will be resulting, they can have antibodies against RBCs, WBCs and platelets. So when there is a reduction of these cell lines or the blood cells, then it is not due to bone marrow suppression, but it is due to peripheral destruction. The clinical correlation are thrombocytopenia. So this is because of the peripheral destruction, because of the antibodies against the platelets. It can even result in a pancytopenia. All the cell lines can be destroyed, but this is not due to a problem in the bone marrow. This is due to an issue that is because of peripheral destruction. The lupus anticoagulant can occur over here too, and similar to APLA, this can also present with recurrent miscarriages. How will they present? Arthritis is the most common and frequent presentation. malar rash may or may not be there. The decreased complement C3 flares can be seen. Lupus nephritis, the kidney involvement will generally be DPGN, that is diffuse proliferative glomerulonephritis. We have another. The drug-induced lupus antibody profile is antihistone antibodies. So how will we be able to distinguish whether the SLE is because of a drugs that the patient is taking or if it is because of idiopathically? So that is can be detected with the antihistone antibodies. The drugs such as minocycline, hydralazine, INH, procainamide and penicillamine can cause drug-induced lupus. What happens in myasthenia gravis? In the motor neuron, we will, and in the neuromuscular junction, the motor neuron and the nerve will connect with each other, right? So in the postsynaptic, there are nicotinic acetylcholine receptors. So when that antibody against the postsynaptic nicotinic acetylcholine receptor happens, it will result in myasthenia gravis. It is seen in women, middle-aged women presenting with diplopia, ptosis, dysphagia, which will worsen with activity. The pyridostigmine, which is a cholinesterase inhibitor, will inhibit the cholinesterase, and so that the choline acetylcholine which is present will act on the nicotinic receptors. So there will be an improved response when pyridostigmine is given. So this can be asked as a treatment. What is the treatment option for myasthenia gravis? That is pyridostigmine or any cholinesterase inhibitors. What is a counterpart for myasthenia gravis? That is a Lambert-Eaton syndrome where there are antibodies against presynaptic. Myasthenia gravis is postsynaptic while Lambert-Eaton is presynaptic voltage-gated calcium channel antibodies. The only difference is that the weakness that presents in my Lambert-Eaton will improve with activity. While Lambert-Eaton is frequently seen associated with small cell lung cancer, myasthenia is seen associated with thymoma. What about small cell cerebellar dysfunction? We have anti-WHO, anti-U antibodies in small cell cerebellar dysfunction. Here, there will be progressive ataxia because of cerebellar dysfunction. So these neurological symptoms will precede or it will accompany the brain cancer. This is a paraneoplastic syndrome which we see over here. Polymyositis, dermatomyositis is that when there is only muscle weakness on examination. Like when there is weakness rising from the chair, when there is weakness climbing the stairs, that is polymyositis. When it is associated with the dermatological features, it is dermatomyositis. So both are seen as a paraneoplastic condition for ovarian cancer, though they can even occur autoimmune idiopathically also. So how do we confirm this? There is anti-Jo antibodies with elevated serum creatinine kinase. So with this, we have come to the end of the autoimmune conditions part 1. I am Dr. Veena Velmurugan with a passion for teaching. If you like my videos and if you want to get mentored by me, you can send me a message in the comments. From that, we can take forward. Have a good day.